Hello everybody, welcome to our lecture on a roadmap for population health. So we're going to cover a number of different concepts during this lecture, and really it's going to kind of set the stage for the rest of this course. So starting off with looking at population health. You can see our learning objectives for this lecture. We're going to look at and be introduced to healthy people. The healthy people is a public health framework that has evolved over time. So we're going to look at how that's evolved. We're going to look at the most current iteration, which is Healthy People 2030. We'll also start to explore the social determinants of health, and then we're going to have an evolving case study throughout this this first several lectures in the course. So we're going to apply this content to this evolving case study, and then we're also going to look at ways, tangible ways, that you as a future clinician can address the social determinants of health within the context of the primary care setting. So woven into the lecture, I do have a few slides that really help guide your reading in the textbook. So this, if you see this copyright Elsevier, this is a slide that is taken from your reading. And I bring this up because I know that in this course there's a lot of reading, but these are some things as you are going through and reading the chapters to really think about as you are completing those readings. So if we think about the healthcare system, so certainly we know that the American healthcare system is not a perfect system. And when we compare our healthcare system to many other developed countries, it's unfortunate, but we really do lag behind in many key health indicators. And so, as you think about that in the context of this course, population health is so important. And what are some of our challenges? Well, we have an aging population. Many of our patients have multiple chronic conditions, and let's be real, the cost of medications are extraordinary. I think we can all think of reflect back either on a personal scenario where we've gone to the pharmacy to pick up a medication, or working with a patient maybe who requires a very expensive medication for a treatment for a specific condition, how impactful financially that can be. And then when we think about financial resources and the fact that they are finite, and really sets our system up and our patients up for those health inequities and those inadequacies or inadequate social and financial resources. So that's something also, if we think about a challenge of our healthcare system. And then this is probably one of the biggest direct stressors for me, I'll be honest, as a healthcare provider. We are pressed for time, right? You get in, you see your patient, you have 20 minutes to get all the information, and usually the person rooming the patient takes the first 5 minutes of that 20-minute slot, plus you have to document and also order, tests or labs or whatever the situation may be. So time and then resources are finite. So these are some of the big bucket items that as you move into the practice, thinking about what those challenges might be and working on developing as leaders, developing creative strategies and initiatives. So what's going to kind of help shape our practice? We're going to spend a lot of time on evidence-based practice throughout this course and throughout this program. The idea of value-based purchasing. So we're going to look at, the thought behind the value of certain tests and certain resources and utilizing those. Then we think about care transitions. So as we move through this course, and when you get to more of the management courses, you'll learn a lot about, management of different chronic conditions. And some of them specifically, we are looking at those specific care transitions or transitions in time. So maybe going from that acute setting, let's take congestive heart failure, for example. A patient who has a new diagnosis of congestive heart failure is hospitalized for a short period of time, and then making that transition into the home. what does that look like? And as a primary care provider, how do we help manage those patients in the outpatient setting? The patient-centered medical home. So this is, again, working on that care coordination piece and making sure patients are having or receiving care that's really directed through that patient-centered medical home, and really thinking of if you think about a wheel, thinking about the primary care provider as the center of that wheel with spokes out to those specialty providers. We want our care always to be safe, effective, patient-centered, timely, efficient, equitable. That is a wish list. And again, we prioritize safety above all else. And then really thinking about patient-centered is also, I would say, a really important piece of this as we're thinking about specifically how to effectively help our patients manage a lot of their chronic conditions that will be seen. And then lastly, the accountable care organizations, or ACOs as they're noted, again, thinking about those health outcomes and really that whole payer landscape as it relates to the outcomes that we're meeting within those organizations. So that is kind of going to be used to guide your reading here and that is chapter 2 in Butaro. Chapter 5 in Butaro gets into the concept of promoting health equity and overcoming disparities. And I have a few slides that talk about this. We're reading that book, The Death Gap, which we're going to spend some discussions time to, further diving into. But if we think about health disparities, really at the core of it is that certain groups or populations have a disproportionate rate of morbidity and mortality, and it's really those circumstances that they experience that contribute or relate to their overall health. And then we think about the social determinants of health. We've identified factors, which we'll get to shortly, of difference factors that can contribute to differences in health in certain segments of the population. So we're going to talk about that more in this lecture. This is a relatively new concept if we think about this in the context of healthy people, the Healthy People Initiative. It's really kind of all come forward, and we'll see that as we kind of move through the timeline of Healthy People, but it is all kind of come forward in the past 40 years plus. There have been different legislative acts that you should be familiar with. I think most of us have probably heard of the Affordable Care Act that made it a requirement for all Americans, U.S. citizens, to have or to be eligible for health insurance. And there's been a lot of, I would say controversy is a fair word to put to it. Again, in one of those things that if you look in the Death Gap, at the end of chapter 1, we're talking about health as a fundamental right. And I think there's a lot of philosophical debates that come out of that. And working in healthcare, of course, we definitely get to see differences in healthcare and insurance and healthcare coverage. But the Affordable Care Act was a very landmark legislation that came out, I can't believe it, but almost 20 years ago, 15 years ago. There are different action plans that have been created through the Department of Health and Human Services, Center for Medicaid and Medicare Services. They also have priorities looking at health equity. And hopefully everybody is familiar with the Agency for Healthcare Research and Quality. They are a national leading agency, and I know in other courses you'll look at the AHRQ as well, but if we're looking at healthcare quality and disparities. So just being familiar with this content. So we have the call to action to promote health equity amongst our profession, but also for our patients. So this call to action is really something, if you're an advocate, even if you're not into advocacy, this is something that's so important, is to really look at, and we'll get into this a little bit more later in the lecture, how our healthcare system really does lead to or contribute to oppression, and how bias and stigma and racism do play a role in the delivery of healthcare. And again, we'll continue to explore this throughout this course. And certainly our behaviors and attitudes are directly related to our experiences and the things that we've encountered, either working in the healthcare system or as a consumer of healthcare. It really, or for our loved ones, it really does impact our viewpoints as well. And so the goal would be to identify and dismantle those forces that are oppressive in our system, and then really looking at and we will do this, I think it's next week in the course, looking at our own internal bias and stigmas. We all have them, and it's just part of being human, but really looking at those with and kind of evaluating and analyzing them through what's called an implicit bias test. It's through Harvard, so that will be interesting. I always find that very interesting to do. And then we're going to really look at and identify our biases, but then also being able to identify where they exist in our healthcare system, because we're going to be better equipped to provide care and to address these disparities head on. So as we're looking at the overview of healthy people, the first initial Healthy People report came out in 1980, and the Surgeon General at that time, General Julius Richmond was his name, really kind of spearheaded this, and then it was taken over by the Office of Health Promotion and Disease Prevention. And so the first iteration, which was introduced in 1980, was Healthy People 1990. So again, it's always 10 years kind of ahead of so goals for the next 10 years. So that 1990 iteration was looking at decreasing deaths through the lifespan, so increasing life expectancy, and then also independence among older adults. Moving into 1990, so the Healthy People 2000 initiative not only addressed decreasing deaths throughout the lifespan, but now looking at healthy life. So not just keeping somebody alive, but actually that health throughout their life, which ties into one of the other aims, which was to increase access or achieve access to preventive services for all. So that makes sense. If we're trying to increase the span of healthy life, we know prevention is huge with that. Also, this was the first initiative that specifically addressed reducing health disparities. Healthy People 2020 really kind of just expanded upon the 2000 goals, and really to aim improving quality of life. So now that's the first time where we see those words. So not just we're keeping somebody alive, we're keeping them healthy, but we're improving quality. So that is certainly something that we've heard and continue to work towards. And then not just reducing health disparities, but a stronger language in looking at eliminating health disparities. Then we move into Healthy People 2020. So this was being introduced right around the time that the Affordable Care Act was being put in place, as we know, in 2010. So we want to, goals for this initiative were to attain high quality, longer lives. So quality and also life expectancy. And then not just eliminating health disparities, but looking to achieve health equity by eliminating disparities and improving health of all groups. So again, even stronger language. And then going a step further to really look at, and this is going to be important when we think about the social determinants of health in this current iteration, is what are those social and physical environments that promote health for all? And can we replicate that? And we really should, as part of that ability to promote quality of life, healthy development, and healthy behaviors across the lifespan. So creating those physical and environmental and social environments that support health across the lifespan. And now we're in Healthy People 2030, which builds upon these more broad goals from 2020. And that is, and we'll talk about these specifically today, focusing on health equity, the social determinants of health, and health literacy. So those are 3 priority initiatives we'll talk about. So you can go back and you can actually click on this framework link and it'll take you right to the Healthy People 2030 framework. But again, 3 priority areas, and all the Healthy Peoples really build upon the previous iterations. But in this one specifically, we're going to look at the idea of health equity, the social determinants of health, and then health literacy. We want really to, again, have that kind of top-down approach. So that vision for what a healthy society looks like. And so they provide that definition, which is a society in which all people can achieve their full potential for health and well-being across the lifespan. So that is a very lofty, amazing goal, vision. And obviously, we would like and hope for all to achieve that. And then as we move down, what is the mission of this initiative? And that is really to promote, strengthen, and evaluate the nation's effort to improve health and well-being of all people. So that is the mission of Healthy People 2030. The foundational principles, which you can see in the framework, that's what really helps guide, okay, is this fitting into that overall strategic plan or that framework for Healthy People 2030? There's going to be, you'll see overarching goals and within each of the areas that allow you or allow them to measure, are these being met? And then the plans of action, those are like your to-do list. Those are going to be the things that allow us as a society or the Healthy People 2030 creators to determine were these goals successful. A couple definitions we should be familiar with. So the Healthy People 2030 defines health equity as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustice, and the elimination of health and healthcare disparities. So very, very strong language. What I'd like you to do now is to just pause where you're at in the presentation or in the lecture and consider a time when you've cared for a patient recently, maybe as in your nursing role, and think about what health inequities did this patient experience. So, there may be a long list. Maybe one or two of them. Was it related to access? Was it related to cost? Maybe transportation? Maybe it was continuity of care. And then we think about Windora, who was introduced in our book, The Death Gap. And there was certainly healthcare inequity that she experienced and inequalities. So we kind of think about that and what was referenced in that book. And is it similar to what you experienced with the patient? Is it different? Something to consider and think about. And then we think about health disparities as a particular type of difference that is closely linked with social, economic, and or environmental disadvantage. So again, let's think about Windora. Health disparities adversely affect groups of people who have systematically experienced greater obstacle to their health. And this can be based on racial or ethnic groups, religion, socioeconomic status, gender, age, mental health, and the list goes on. Cognitive, sensory, physical disability, sexual orientation, gender identity, geographic location, so thinking about those very urban or very rural areas where access may be an issue, or other characteristics that have historically linked to discrimination or exclusion. So I'll give a quick scenario or a quick example. In my clinical practice, I see patients of all different socioeconomic status, but working in a specialty clinic focusing on obesity medicine. And I see a ton of socioeconomic impacts of health disparities. So an example is recently a medication was approved by Medicare, which is a big deal, for the treatment of obesity. And well, I should back up. Medicare actually approved this drug for the treatment of secondary cardiovascular prevention. So for a patient who's had an acute MI or who has documented known ASCVD. And so it's a huge deal because this drug is very, very expensive, and Medicare does not cover it, excludes it for obesity. But the drug added this secondary indication after research showed that it was effective in reducing secondary cardiovascular prevention, or secondary cardiovascular events. So that now I'm thinking, great. So I write the first prescription for a patient because she has Medicare and living, on a fixed income. It goes through without a prior authorization. I'm so excited. I tell the patient the medication was approved. Go ahead, pick it up. She's so excited. It's going to hopefully be a really good medication for her. She goes to the pharmacy. It's $250. And she calls me and she's like, I went through my insurance. It's still $250. I can't afford that. And I said, yep, you're right. So the drug has the indication and it's shown outcomes that it can impact and improve health. This patient, it's cost prohibitive for. And so again, we compare that to somebody else who may be in a different socioeconomic status, $250 a month out of pocket for them. They'd be able to pick up the drug, start the drug. Very different in terms of health equity or therefore health inequality. So that's just an example that I experienced within the past couple of weeks. I'm sure all of you can reflect on something that you've seen similarly in your work as a nurse. Now we're going to touch on one of the other priority initiatives, which is patient family education and health literacy. So one thing I'm going to stress, and this will come out in subsequent slides, health literacy is so much more than giving the patient the information. It's really about assessing their understanding and needs and making sure that not only do they have the information, but they feel that they can act on it and that they can make informed decisions for their health. That's a big undertaking. So we're going to talk about the 5 social determinants of health and how they certainly impact healthcare disparities, as well as this idea of health literacy. And one of the social determinants that are concerning would be that whole idea of health literacy and language literacy as it relates to the social determinants of health. There's 2 different divisions or 2 different kind of sub areas of health literacy, and that's personal health literacy, which is the ability of the individual or person to seek out, understand, and apply the information learned to make informed health decisions and measurable health actions for themselves or for others. So that's at the individual level. And then at the organizational level, this is really thinking about systems. And so our systems in which we work have the ability to clearly communicate strategies that are culturally inclusive and help support patients navigating through the healthcare system and are also equitable to all. So navigating our healthcare system can be so challenging for people. And so really, then we think about that organizational health literacy, it's making sure we have, or our systems, our healthcare systems have systems in place, or structures, I should say, in place that help communicate how to navigate. And so, an example might be a patient gets a new diagnosis and will require them to work with multiple specialties, let's say, for treatment. Oftentimes there within healthcare systems now are those navigator roles that help patients navigate through the healthcare system. And that's so important, not only for patient satisfaction, but also for access, timely access to care, and then also allowing them to receive equitable care. And so, as a primary care provider, we may also help facilitate some of those navigator like situations. And we must be aware within our own organization how those systems look, what's in place. And a lot of times we may find that there aren't great systems in place. So that's certainly an area for leadership and advocacy in a way that you can get involved. Other things to think about with patient family education, health literacy, is that whole idea of our senses. And so we need to make sure that we have mechanisms in place for communicating with families, with patients who may have difficulties with hearing, language comprehension, eyesight, reading comprehension, understanding numeracy, and then also technology. So, telehealth is great. It's great. It's a wonderful way to be able to provide access to people who might not have access. However, we need to ensure that our patients understand technology and therefore might not be appropriate for all people and also have access to the technology. We want to make sure that we don't get too medical, right? And that we present information in a number of different ways. How many times, and maybe this hasn't happened to you yet, but I know it will at some point, where maybe when you're in clinic, you'll go in, you'll get some information, you come back out, you tell your preceptor, they go in, they ask the same questions, or so we think, they get a different answer. And sometimes it's the way the information is presented, it might be just slightly different. So again, that would be also something with that those iHuman cases that can be frustrating, is when we think we ask and communicate something, but really maybe the patient interprets it as something different. We want to be cognizant of the fact that only, and I would have thought this was actually lower, but 36% of Americans can comprehend basic health information. So if we give them those patient education handouts, less than half of those patients are really going to be able to understand that. So we need to provide them with additional, and here's the key, credible health information resources. Anybody can go to Google and look something up. Now, whether or not they get credible information, that is often a challenge. Numeracy, that's looking at quantitative data to make healthcare decisions. So sometimes people's eyes will glaze over when we talk about this, but this is looking at, okay, trends and looking at, the evidence as it relates to kind of the analytical side. And so that sometimes can be used, especially with people who appreciate those sort of, analytical thought processes that may be helpful. I use, like, for example, when I'm, patients want to know sometimes, well, how effective is this drug going to be at helping me lose weight? I like to show them visually a bar graph, and I'll show them placebo versus drug with the different trials they've been tested, and we talk about them because I think visually for people, sometimes I could say, 18% weight loss, but then to put that in that context for patients, sometimes they want to see, okay, what's the difference between one and another, and that visually helps represent that. Technology, again, we kind of already talked about this, but being able to have knowledge of how to use tech devices. So thinking about our diabetic patients, like giving them glucose, a CGM, having them, do they know how to use it, set it up. Some of the telehealth platforms now, they're using Bluetooth monitoring for different conditions. And so making sure patients understand and know how to use those. That's all kind of falls into this bucket as it relates to health education and literacy. So this is really kind of redundant, but an overview of how we would go about. We want to conduct a health literacy assessment. So this is going to be individual for our patient. We're going to think about what interventions, so how, whether it be more of a demonstration, maybe it's, using language line, maybe it's providing handouts and using the language line to review that key points. Making sure culturally responsive care is important, and then overcoming patient barriers. So really we should not be using family members or friends to be interpreters. We want to use approved professional interpreters. And one thing that I actually encountered recently, I had a student with me in clinic, and we were doing an exam, and the interpreter actually stopped. And I think it was a really good learning opportunity for the student, and said, when you're talking, make sure you're talking and making, direct contact with the patient, eye contact with the patient. And I thought that was really interesting, because I was kind of thinking about it, and I'm like, and I think the student was taken a little bit off guard, but then reflected on it later and was like, yeah, that's a really good point. Like, we want to talk, and we're talking to the interpreter because they're translating the information, but ultimately we're really talking to the patient. So that's just a subtle thing, and I was like, oh, that is so, like, now whenever, it's like the first thing I think about when I'm working with a patient is, if there's an interpreter present, I want to make sure that I'm also having eye contact with that patient, and that's really the priority. So this slide just looks at the health literacy kind of from a pictorial or graphic approach. So health literacy, again, as we think about personal health literacy, so much about not only can they use, but can they apply the information. So not just here it is, but can they apply that information and really, as it relates to shared decision making. So what we may want for the patient may not be what they want, and then taking the information we give them to help them make those informed decisions. And then as we think about organizational health literacy, that's really looking at not only one's ability to move through an organization and that approach, but then also the health and literacy of the population. And really allowing every patient, every family, our community to be able to, from an equal opportunity playing field, be able to find, understand, and use the information that they have. So that's really what the system or the organization is tasked with as it relates to health literacy. So I love this quote, because penicillin, so this really speaks to prevention, right? Penicillin may be indicated to cure pneumonia, but it alone will not stop the roof from leaking. So yes, if we are going to get pneumonia because we are living maybe in an environment where we have our roof is leaking and we're being exposed to maybe mold, then some bacteria that we inhale gets into our lungs and develop pneumonia, the penicillin can help treat that, but we're not treating the root issue or the cause. So as we think about with this whole course, and really the primary care world, so much is about preventative health, and that's kind of what we're going to shift into thinking about and looking at. So this slide actually probably belonged earlier with the Healthy People 2030, but this is kind of gives a little bit of a roadmap to look at how Healthy People is leveraging their goals to be able to help address health equity. And so, we know that they've got the priorities identified, being health literacy, eliminating health disparities, and then social determinants of health. They use data, so data is everywhere now, and being able to collect that data to really track and inform health, to track health disparities, that's then used to inform program and policy development. So applying that data. I think a tool that I will show you guys in a little bit, some of the resources, evidence-based resources in the community that you may be able to access and utilize. Then we think about stories of how different communities or people are addressing health equity. The framework, again, that I touched on earlier that you have a link to, this is can be used to help develop a model for program planning. And then again, coming up with those shared definitions that help promote those uniform definitions that help promote a shared understanding for all. So this is the root of, I must have had a slip of my mouse that moved these slides around, but when we were talking about the penicillin and we're thinking about, penicillin is treating the pneumonia, that's above, we're above the tree, right? And then we think about the roots. I love this picture. So the 5 domains of the social determinants of health. So you can actually link to each of these and see what is in each of these or what comprises each of these social determinants of health. And we'll talk about these. I'd like for you to think about these also in the context of the book we're reading, because we know that social determinants of health also definitely contribute to wide health disparities and inequity. So, for example, let's just take the example of nutrition, which could fall into the neighborhood and built environment, okay? So people who don't have access to the grocery store, so food deserts, people who live in food deserts, they don't have access necessarily to grocery stores, so they may not have access to healthy foods and they're less likely to have good nutrition. So they can be at higher risks for conditions such as heart disease, diabetes, obesity, because again, they may not have access to healthy foods. If they're getting their foods from a gas station or a convenience store, right, those are going to be ultra processed for the most part, ultra processed foods, and very different than somebody who can, 2 blocks away, walk to the grocery store and get access, to healthy, affordable, that's also a key, fruits and vegetables. So, it's not enough to just say, okay, we need to, promote healthy choices. So we need to promote, let's take another example, walking 30 minutes a day, or in future lectures, we're going to look at the physical activity recommendations, okay? So let's just say the recommendation for adults, which the majority of adults don't meet, is at least 150 minutes of moderate intensity physical activity a week. So we can promote that. We can tell all of our patients that they should be doing that. But if they don't live in a safe environment where they can go outside and walk, or they can be active, maybe they don't have space or the ability in their home to do it, how we need to help solve that problem. It isn't just promoting it, it's figuring out how to partner and solve that. So again, as we think about bringing this back to Healthy People 2030, one of their main goals really ties into the social determinants of health, because it's looking at each of these 5 areas and how we can create those social, physical, and economic environments that really set people up to achieve their health and to eliminate health disparities. So again, as we think about each of these areas, I would encourage you to look at them. Most of them you probably can figure out what would fall into each of them, but healthcare access and quality. So, do they have access to affordable quality healthcare? Some would say, again, using that example of the book we're reading, 3 hospitals within a mile radius, probably very different in terms of healthcare access issues may not be the problem. Maybe it's quality. Economic stability. So again, do they have the financial resources, access to education, and quality. So thinking about health literacy and thinking about access to high quality education as an initiative and priority, the neighborhood and the environment. So that could be the neighborhood where they reside, where they work, really where they spend their time. And then those social and community contexts. And that's so important too. Who is in their safety net and do they feel supported in their social networks and in their communities. I love this slide because this really focuses on the framework of the social determinants of health and how we approach them from a clinical and a public health perspective. So as a healthcare system, we tend to focus more on the downstream factors, but we really need to also really think about the upstream factors and how they impact our patients' health. So, we may talk with them about chronic diseases, so hypertension, diabetes, other communicable diseases that they may be coming in for treatment. But we really need to think about how risk behaviors impact that, smoking, poor nutrition, physical activity, violence, but also going back in reverse, how are the patient's living conditions, their social environment, their work environment affecting their behaviors, which are then in turn affecting their injury. Going back even further, looking at the agencies and the government and the associations that make these policies and create these living conditions or environmental or working conditions that impact behaviors that then impact disease and injury. And then if we go further back again, we think about some of the social inequities. And so really the emerging area of public health is focusing on those upstream effects. We seem to find ourselves more in those downstream effects. And I found this interesting that there was a study done by McGinnis that found that social determinants of health account for 80% of an individual's health status, but really our healthcare system only addresses the remaining 20%, so where these arrows are. So we really need to think about examples of these upstream factors that really do impact healthcare for all. So how do we address the social determinants of health in practice? So these are kind of those takeaways for you. These are ways in which you can assess the area deprivation index. That's really interesting. It looks at different neighborhoods within, Wisconsin, you can put in your zip code. And then I would encourage all of you to do the Robert Wood Johnson's life expectancy by zip code. Put in your zip code and then maybe put in a zip code of a really urban area or another area. You could put in a zip code of somewhere you've lived in the past to see how life expectancy can differ greatly. In some places upwards of 10, 15 years. So that's really interesting. Even just like for patients, putting it in, depending on where you're working, if you're working in a larger area. And then screening. So these are ways we can screen for social needs, social determinants of health. I love the ACT, this one, the Care Everyone Project. So this helps to link patients or with resources in their community. And then if you're into more of the advocacy, which I would encourage you all to be, these are different social determinants of health legislation that's currently going on. That would be a way you could act as well. So now we're going to take it to our evolving case study. So how are we going to apply these in practice? So you have a 32-year-old African-American female that comes to the clinic for a new patient checkup. So she's brand new. She's coming in because she's losing insurance at the end of the month. She's having a job loss, job change. She doesn't know when she'll have insurance back. She doesn't have any real health concerns other than feeling tired more than normal, but she's working 2 jobs, taking care of 2 children and her mom, who lives with her family after she had a stroke 4 years ago, and her mom requires assistance with most of her activities of daily living. So this is her subjective data. You can see she has a history of obesity, preeclampsia. She delivered a premature child at 32 weeks due to the preeclampsia. She's had 2 C-sections. She doesn't take any medications. She's got no allergies. She uses marijuana daily to help cope with her stress. She smokes a half a pack of cigarettes for 15 years. She does not drink alcohol. She lives with her family on a top floor apartment with 2 bedrooms with a mom who's had a stroke, so that's probably not ideal. She's a cashier at a local drugstore, and then she also does housekeeping 3rd shift. She doesn't have any safety concerns in her home, but she has been exposed to a history of interpersonal violence, and she has high levels of violence in her neighborhood. She does live below the federal poverty level, and so she has concerns about being able to afford rent, monthly expenses, and she has a history of homelessness. Her last was 4 years ago. She does not have any close social connections. So again, thinking about all the social determinants of health, she's either always working or caring for her family. I put in pertinent health maintenance. She does not exercise, but she's active in terms of chasing around her kids and then helping to care for her mom. She typically eats 1 meal per day, and she does frequent the food pantry for food, which is I always ask about because food insecurity is a huge component as we're thinking about social determinants of health and developing, treatment plans for our patients and working with them. Immunization, so she's got no records to review. So she has lived out of state, so additional work will be needed to be done to collect what immunization she's had. It's been several years since her last PAP. She has not had a dental exam in over 10 years. She doesn't have dental insurance. And then she hasn't had her eyes checked since she was in elementary school, so probably about 20 years ago. So family history, you guys can read through here. So if we're looking at, significant family history, definitely has physical as well as mental health diagnoses in her family. And she, again, is the primary caregiver for her mother. For your purposes, or to make it easier, I highlighted pertinent findings and pertinent positives in her review of systems. So you can kind of read through these as we work through the case study. It'll be helpful to know this information as we move week to week. And then her physical exam. So she does have, she is a female with class 2 obesity. She has a high blood, she has hypertension. Based on this reading, we'd have to officially diagnose her. She'd need a subsequent elevated blood pressure. Her BMI here, she's got these hyperpigmented, thickened patches of velvety skin in her arms and the nape of her neck, which is a sign of something. If you don't know, definitely go back and look that up, as well as multiple skin takes on the nape of her neck. So you want to look that up as well. Always for part of your nutritional assessment, you want to know, does she have good dentation, because that can impact certainly a nutritional status. Everything is normal with her breast exam. She doesn't have any swollen lymph nodes, no lymphadenopathy, no thyroid abnormalities. Her heart rate rhythm is regular. Her respiratory exam is normal. She does have rounded abdomen with adiposity and striae, so those stretch marks, and then she's got her C-section scar. All the rest of her exam, her genitalia, her GU exam is normal, musculoskeletal is normal, and neurologic is normal. Fun little evaluation. What additional screenings, level A, level B evidence, might you want to offer this patient? So you can go and think about that and challenge yourself just to kind of apply some of the health assessment content. So we've probably all taken care of patients that have a long list of concerns that they come for. And so this patient has a lot going on. She would be a patient that has many needs you'd want to address all at one time. And that's called what I call the kitchen sink. And that can be very hard and very challenging also as we think about our self-care and how we, by caring for patients like these one after the other, this can really lead to not only compassion fatigue, but also burnout. And so compassion fatigue is that idea of you're giving, so you're emptying your cup emotionally, physically, sometimes even financially. And so you kind of get to a point where you're at this, loss for empathy because you've given so much of yourself that you feel that you don't have anything left to give. Perhaps you've already felt like that in your professional career. I can speak honestly that I have definitely felt that way. So that's why self-care is so important. And actually, with this new edition of your textbook, I'm so happy they added a chapter on self-care, which we're reading this week, chapter 10, because it is so important to practice self-care. And really, it's a part of the new essentials for nursing programs is to really look at that and make sure that that's something we include in our curriculum. So you'll definitely get that here. Burnout is something we want to avoid. Probably we experience at different times for the other, but really the key is how are we going to take care of ourselves? What does that look like? What do you need to do? And I would encourage you to make a self-care plan. One idea that I've done in the past is you make a self-care plan for yourself at the beginning of every semester, because it might look different every semester depending on what's going on. Or, you make a self-care plan for yourself when you're in school, and then that looks probably different when you take your first job, the first year out of school. What are your non-negotiables? What do you need every day for yourself? And it's not selfish. Self-care is not selfish. It's really an important part of being a good provider. Is you're thinking about how you can support others, so your colleagues, modeling healthy behaviors and self-care. So it is not a badge of honor to, go to a 12-hour, I'm sure we've all done it, a 12-hour shift without going to the bathroom, right? Like that's not, yes, as nurses we do it, but it's not something that we necessarily should be celebrating, right? And so it's really recognizing and modeling those healthy behaviors, being respectful of others, and everybody copes differently. So just giving people their space. Never be afraid to ask someone if they're struggling. We know this from health assessment, and probably you've learned this in other courses. If you ask somebody if they're suicidal, that does not mean that you're planting the seed in their head to be suicidal. We should always ask about that. And then we're also, assessing our patients, and also, helping support others and get them the support and help they need. These are just different evidence-based screeners. You may use them in practice with patients, but certainly, again, for yourself, as you're thinking about how you can support your colleagues and your patients, the first thing you can do and the best thing you can do is to take care of yourself. So I plugged that in here because we, again, get to our case study. And Miss Jones, we're going to come back to her every week. So this is just planting the seed. But what I want you to think about this week as you move through the week is your self-care plan. So what are you going to do? So I would encourage you, write it down, make something visual. If you're a visual person, spend some time coloring a self-care. Spend some time thinking about how you're going to what your self-care plan is maybe for this next 8 weeks or over this summer or next year as you continue to move through the program. Whatever that is, make that plan. And what does it look like in your professional world as well? And then the social determinants of health. So let's take Mrs. Jones. And if you think about those 5 social determinants of health, just what you have from her history, where do you see health and equity for her as it relates to these social determinants of health? So those are kind of your 2 takeaways from this lecture. Well, more takeaways, but your 2 things to reflect on as you move through this week. There'll also be a discussion post for this week related to the book, The Death Gap. All right, so that wraps it up. All my references are here. If you have any questions, please let me know. Thank you.